Hi, I'm Wesley Walker of the New York Jets, former All-Pro wide receiver. You're watching Bridge to Health at Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow. And for those of you who have not watched our show in the past, each week we have a specialist from a different healthcare discipline that we work together with as a team that helps you, the patient. Very, very important that your treating doctor is in constant communication with other doctors who are treating you, so everybody's on the same page, everybody knows what each other's doing, and you can get the best diagnosis and the best treatment. Also each week, we bring different healthcare specialists in to talk about different techniques and different things that are new in their profession, which you might not know about yet. This week, we have the honor of having a really good friend of mine and a really great chiropractor, Dr. Todd Goldman. Hi, Todd.
Hi, how are you?
Excellent. Thanks for joining us this week.
Thank you.
Todd, you're a chiropractor. When did you graduate chiropractic school?
1995.
And what school did you go to?
Life College.
Nice.
Atlanta, Georgia. Atlanta, Georgia.
And how did you become a chiropractor? What made you want to become a chiropractor?
Well, my father was a chiropractor. He recently retired last year. But I realized that at the time I was trying to figure out what I wanted to do. I wanted to do something in medicine. I never realized why my father would come home with pies, why it was homemade pies and vegetables and fruit and all these things my father would come home. Why I would get birthday presents from people I never met and Christmas presents or Hanukkah presents. And I never really spent time in my father's office. I never really spent the whole day. We would a little bit at a time, but never really spent the whole day. So one day after I was in undergraduate school and majoring in biology, and I decided to spend on a break the whole week with my father. And from that week, that's what I knew I wanted to do.
You saw the kinds of patients he treated, the kinds of conditions, how happy they were with their results.
The fact that you didn't have to give them medicine or cut them or perform surgery, and you're getting them better with your hands, that really appealed to me.
Hands-on work.
Yep.
Nice, nice. What age were you when you got your first chiropractic treatment?
I had torticollis when I was a newborn.
Torticollis being a stiff neck.
Stiff neck.
Yeah.
I mean, my neck was
the babies are born like this, but their neck's stuck.
So I was probably a day or two old.
Nice. And do you take care of a lot of infants in your practice, or any infants?
Yeah, we take care of infants. The main thing we take care of, we have a lot of pediatricians that refer to us, and the main thing is torticollis.
Right.
I mean, that's a big thing.
Okay, now I obviously, or I better know, why we take care of infants, but tell me anyway so the audience understands why it's important to have at least an infant checked and then treat it if necessary.
What happens if there's nerve interference, if the vertebra is not moving the way it should, it's going to irritate the nerve. And from there, that nerve irritation could cause a multitude of health issues.
Such as what for babies?
Ear infections.
Middle ear infections.
Middle ear infections is huge.
Right. GI disturbances, colic, right?
Colic. Both of my kids were colicky. And once I started really taking care of them, it went away.
Right.
So it was great.
Just so you and the audience have a little better understanding as to exactly how a chiropractic treatment and adjustment might affect an inner ear infection or an inner ear problem. The upper cervical vertebra in the neck and also the mids, if those vertebrae are out of place and pinching the nerves in the neck, those nerves can go to muscles in the neck, which now become spastic, contracted, That then blocks the lymphatic flow. The lymphatic vessels are little tubes or channels which come from the inner ear and flow down, and it takes the fluid out of the inner ear so it doesn't build up behind the eardrum, which causes an infection. So if you got a child who's got a subluxation, which is a bone out of place in the neck, which is causing muscle spasm, which is blocking that flow of fluid from behind the eardrum, that child will develop what they call an otitis media, or an inner ear infection, because that fluid backs up, swells the eardrum, and it becomes infected. And that's how a chiropractic adjustment can break that cycle of spasm by relieving the nerve flow and letting that fluid flow, right?
Exactly. I mean, probably out of any condition that we treat, the best results is with kids with ear infections.
Right.
Because it's so simple as far as what the cause is.
Right.
You know, with low back pain, there's a number of different causes, especially when we become adults.
Right. Right.
But ear infections.
Right. And medical treatment for chronic ear infections would be to pop holes in the eardrum, put little tubes in, so the fluid comes out the ear instead of draining the natural way it should down. And let's face it, sometimes even with the work we do, the tube or the anatomy is just such that they may still need that, but not as a first resort.
Exactly.
Right?
Exactly.
So there's always there's always a time and a place for the team members.
It should
conservative first, then more non-conservative later on.
Yeah, exactly. You know, a lot of times what happens, they're given antibiotics, and it's not always a bacterial infection.
It's usually a viral infection.
Exactly.
Yes.
So, you know, they're given, that doesn't work. All right, it's not working. Tubes in the ears.
Yeah. And for those of you in the audience who might not know, most people do, viral infections, antibiotics do nothing for viral infections. They're given as a precaution, even if the doctor thinks it's viral, as a precaution, just in case it's bacterial or a secondary bacterial infection develops after the viral clears up. And research for years has shown that pediatricians years ago, probably not as much today, would write a script even though they know it's viral, just so the parents have something to take home and they feel better.
Yep.
That they've done something.
It happened, exactly.
Right? And we know how dangerous it is today to have too many antibiotics given over a lifetime, because now we develop bacteria which are resistant to those antibiotics, and now real infections are hard to treat.
And now we're having pediatricians referring to us for those types of problems.
They're referring to us because they want to see if there's a conservative method, so they don't have to keep giving them medications if they're not necessary.
Yeah.
Yeah, it's pretty cool, right?
Yeah, it is.
Did you ever think that would happen when we were in school?
Never.
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 But it's nice to see. Again, when we were in school, a pediatrician would never refer to a chiropractor. No. An orthopedist would never refer to a chiropractor.
They weren't even allowed.
Right. They were bylaws.
The American Medical Association forbid it.
Yeah, they had bylaws in which they had to remove because of a lawsuit we had against them.
Yep.
But it's so nice now to be able to have these people actually working in our offices,
Exactly.
and if not in our offices, outside, where we could talk to them and refer patients back and forth without that conflict, where the patient now can go over that bridge and have the best of both worlds.
Yeah, exactly.
Right? Let's talk now, because you have some pretty interesting looking devices sitting on this table right here. These are some specialized chiropractic adjusting techniques. The traditional chiropractic adjusting techniques are with our hands, very gentle and specific movements with our hands to move the bones back in place. These are more advanced, more technical devices for different purposes.
Exactly.
So let's first talk about that gun you have there. What is that called again?
Impulse adjuster.
Impulse adjuster. Can you pick that up and show us how that works and how that's used?
Okay. Basically, what happens is, you know, what you and I do is we don't do just one type of adjustment on every single patient.
Right.
You and I both know a number of different techniques.
Right.
Because not one technique is good for everyone.
Right. And let me interrupt for 1 second. Let's get back again to the pediatric, the children who get adjusted. A lot of people think, oh my God, I'm not going to let my kid get adjusted because they see us do this and this, and the pops that they see the adults get, and automatically they think we're going to do that to the kid.
Yep.
They have to understand that we have special light fingertip techniques which go along with their respiration, where there's no force, there's no heavy impact with that. It's totally safe for that baby, right?
Yeah.
I just wanted to make that clear.
Yeah, no, it's a huge thing.
Huge misconception. So what does that gun do?
This will get the vertebra to move the way. You know, the vertebra is not moving. The vertebra move by joints, and sometimes the joints lock up, and they don't move the way they should. So this helps get that vertebra to move the way that.
So you would put the point. You would put the point of that instrument on the vertebra in the direction it needs to move back in place.
Exactly.
And then what do you do?
And then you push the trigger, and then that's it.
I see, and it gives like impulses.
Impulses
into the vertebra to little by little shift it.
Very light.
Very light.
Very light.
Would you use something like that on a baby?
Definitely. Okay. I mean, there's also different tensions that we could put on it. I mean, very gentle.
So there's different buttons you can press on that, which regulates the amount of force.
Exactly. Yeah.
That is, and you probably put on the lightest force when you have a little baby or something. You want to make a correction.
We can do that. Also, it depends on. You don't want to. Let's say you're adjusting the neck. You don't want to put a heavier adjustment as you would, let's say, the low back.
Right.
So there's different tensions that we can use.
Right. You may take an instrument like that, let's say on a senior citizen, that may have plaquing in their arteries in their neck, or they may have fusion of some of the vertebra, where you can't put any type of force in there safely. You would use something like that, right?
Yeah. People with osteoporosis.
Right.
We have a number of patients that are in wheelchairs, and they can only just bend forward
a little bit,
and we get in. And
yeah, that's pretty cool.
Yeah,
that's
it
pretty
works
cool.
out well.
Nice. Let's see your next instrument called the thermoprobe.
All right, thermoprobe. Basically, what this does, this would be smack myself on the face.
I'll adjust you. Don't worry. When we're done.
Yeah, I'll need it. What this does, this will plug into a machine. You press a button. Depending on if you want what the condition is, if it's acute condition, if it just happened, if there's swelling, if there's inflammation, if it's hot, you press a button. Within 2 minutes, this will turn 30 to 32 degrees.
So it'll get cold. Can you just hold that up so the audience can see it in the cameras a little bit? So you put that metal surface right on the part that's injured.
Right on the part that's
and instead of using ice, you move that back and forth.
Move it around.
And it's 32 degrees.
32 degrees. You break up inflammation. It works out. I mean, unbelievable. Right. So unbelievable that we haven't. I bought one at first, and now we have them in all the rooms.
I know when you put ice on someone, a lot of times in the first 2, 3, 4 minutes they start complaining it hurts because of the ice. Do they still feel the pain of ice with that?
No.
Really?
No.
Is it a deeper penetration than just ice on skin?
It's deeper. It's deeper. And also we're rubbing it. We're rubbing it back and forth. We're trying to break up, trying to get that inflammation or that swelling, just to reduce that and try to move it around a little bit.
Okay, and then you hit another switch and it heats up if you want, right?
Yep.
To what temperature?
92 degrees. I think 92 degrees.
Nice. And that's if you want to, like, somebody has spasm, you want to get heat into an area, increase blood flow, circulation.
It break up scar tissue.
Right.
I mean, what we can do is we can leave this on its side and really break up and go deep in there.
With the edge. You're using the edge of the metal to get in there.
Yeah.
Interesting.
I mean, we have great results with this.
And so now let's look at the last thing you have there today.
Last thing.
Called the cold laser. I'm sure the audience has heard a lot of things about lasers in every healthcare profession. You have lasers for toenail fungus. You have lasers for tattoo removal. You have lasers in a whole bunch of different applications. What is the application of this laser?
Well, there's basically two different types of medical lasers. There's diagnostic, there's surgical, and there's therapeutic. And this is therapeutic. What this does, it's cold laser. You don't feel it. It might warm up a little bit, but that has nothing to do with the treatment. It shoots a laser out, and you just put it over the area. That's, let's say, a disc herniation. The other day we used this. Patient can hardly walk. He actually had to be carried in by 2 people. We put this right over the disc. It reduces the inflammation. It can get deep in there.
So it's cold?
It's not. No, you don't even feel it.
No, but I mean...
It's this cold laser, but...
Because normally cold will reduce inflammation and heat will increase inflammation. So does that laser go in and cause...
The ultraviolet light will cause the inflammation to decrease. Exactly. Exactly.
So can you regulate like how far that penetrates?
Yes, you can regulate how far it penetrates. You can regulate. This will tell you, depending on what program, there's a number of programs you use.
Right.
This will tell you. I could put in a program and it will pick up the greatest points of inflammation.
Really?
So let's say you're doing a tendonitis on the elbow,
Like a tennis elbow.
So I'll go around and it will beep if it finds a great point of inflammation, and once it beeps, you hold it there in that area. So it's penetrating.
So it's not only therapeutic; it's diagnostic too.
Yeah. It'll show you exactly where to do it.
Have you gotten good results with that?
Great results.
Really? What other? Go ahead.
I've had medical. I've had cold laser therapy machines. I had 2 others before this one. This one's from Russia. This one's by far the best one that I've had.
Wow. What does something like that cost to purchase as a provider?
I think this one was about like $5,000–6,000.
Okay. All right. What other conditions can that treat?
It could reduce disc herniations.
Right.
A lot muscle spasm.
It reduces muscle spasm?
Reduces muscle spasm. We have
carpal tunnel?
Carpal tunnel is great. Carpal tunnel is unbelievable with this. We have a lot of patients coming in, and they either had carpal tunnel surgery before, and the problem is when these people have surgery, I understand when you're in pain, and you want to get rid of the pain as quickly as possible.
Right.
But the problem is the surgery might fix the problem temporarily.
And cause more scarring.
But once you have scarring,
right,
you pretty much, for the most part, the surgeon can't go back in and take the scar tissue out. Sometimes you can, but depending, if it's on the nerve,
right,
it's done. You can't do anything about it. So we have a lot of people who have had carpal tunnel that didn't work, carpal tunnel surgery that didn't work, or carpal tunnel surgery that worked for a period temporarily.
Right. And
due to scar tissue, they have problems. Or people were told that they need surgery and they came in to us.
When you go into your office, you have that picture on the wall before and after. I think it's a shoulder with calcium deposit.
Yeah,
is that for this machine?
No, that's another machine.
What is that machine?
That machine is a sonic pulse machine.
Ultrasound?
It's not ultrasound. It's vibration.
And that will break up calcium deposits within joints?
It's unbelievable.
Man, you got everything over there.
I couldn't bring that one. I couldn't bring that one in. But that one is wild because that one, what we do is if you have lithotripsy, if you have a kidney stone,
right,
and then they lay you on your stomach on a disc, and the disc will shoot impulses through the body, and they will target that kidney stone, and it'll break up the kidney stone.
Right, right.
Where that is targeted, that disc,
right.
This machine that we have, instead of targeting just a small focal area, the sonic pulse machine will rub it on that area. Let's say it's a calcium deposit in the shoulder.
Right.
And it will spread out. So the vibrations will spread out, and it'll basically explode break up the calcium deposit.
Wow, and I've seen those before and after pictures. They're pretty impressive.
It's wild.
Tell us a little bit about that machine you have in the back room where you lay a person on their back, you strap them in, and it tractions them.
Oh, the decompression table.
Spinal decompression.
Spinal decompression.
Exactly. We see a lot of that advertised on television. We see a lot of it, we hear it on the radio. Tell the audience exactly what that is.
Spinal decompression. What happens is if you have a neck issue or a low back issue, specifically a disc issue, a disc bulge, stenosis, anything like that, the patient will lay on the table, and we have a specific, we'll strap them in. They'll be on the table for about 15 minutes to a half an hour, depending on what the issue is. And it will gently pull the patient and take the pressure off the disc. Now we're not, we're not trying to get. Let's say you have a herniation. The focus is not to, we're going to get rid of the herniation. Right. I've seen it happen before, but that's not really the main focus.
Right, right.
The main focus
is some relief.
Give them some relief. Right. Take that pressure off. Right. Open that space up.
Right.
And when that happens, hopefully they'll get
the way I try to explain to my patients the difference between that And it's another technique we have in special tables, we both have them in our offices, called flexion distraction technique, is that the spinal decompression, you're taking the whole spine and you're doing this.
Yep.
Every vertebra in the low back, every disc is tractioned out. The discs, which are out of position, have a chance to go back a little bit. But then when they come out of it, it goes back in. The difference between that and flexion distraction technique, again, a different table that you and I both use, is we can specifically, with that table, contact our hand above the herniated disc, open up that space specifically where the disc is herniated, and then in a three-dimensional plane, traction the vertebra in a position to make that disc reduce.
Yep, exactly.
That's the main difference. You agree?
Exactly.
Right.
The spinal decompression is more for a diverse area as far as, a lot of times what happens is the patient will have a herniation and or a disc bulge,
right,
and then they'll have stenosis. So
again, I just want to tell the audience, stenosis is when the spinal canal, instead of being its normal shape, is narrower than normal, so it's less room for the spinal cord to pass. Okay.
With spinal decompression, sometimes people get confused. They think it's regular traction,
right?
What they used to use, and
right.
some people still have traction
right.
tables. Spinal decompression, what's done is with regular traction, the muscle, the machine will pull, but your body senses that pulling and will tighten up, and so you get a lot less of a pull. Spinal decompression is a lot more benefit. You're going to get a lot more of a pull because those muscles don't tighten up
right.
to try to fight that pulling.
Right.
It does it in a way where the guy who invented the table, he went across the world and he calculated these numbers and figured how slow does it have to pull before the muscles will start tightening up.
Right.
So the table, you'll enter everything that you have to enter. Everything's computerized.
All computerized, yeah.
And you enter it in, and it will pull in stages, depending on what you enter in there.
Right.
And depending on what he found.
Because if you pull too quick, they're gonna go into spasm.
Yeah, they're gonna tighten up.
Wow, interesting. So let's just, because we're getting toward the end of the show, let's just sum up what our approach is as chiropractors and us working together. Is conservative first, a little less conservative later, and if necessary, we go to the more invasive techniques, correct?
Yeah.
Okay. So, as I explained in the past, typically, if you're a patient and you're just in a chiropractor's office, or you're a patient, or you're just in a physical therapist's office, or you're a patient, or you're just in an orthopedist's office, or a neurologist's office, chances are those guys aren't going to be talking to each other, right? And chances are they're going to be saying that what they're recommending is better than what anybody else is recommending.
Exactly.
Where the truth of the matter is, that patient might need all of them done at the right time, at the right place, and in the right sequence to get the maximal benefit, right?
Yeah, exactly.
So a typical example I give is that we have a patient come into us from a car accident, a trauma, a slip, or fall, or just they woke up one morning and their neck is bent to the side. We do an exam on them. We determine they have a vertebra out of place, pinching a nerve, and they're in spasm. They're in inflammation. They have swelling. Those devices you just talked about are going to get things a little under control so that we have an easier time making a correction, right?
Yeah, it works out great.
Now, after we make a correction, if we're not able to make a correction because there's still spasm, we may refer them to a pain management guy to calm things down a little bit. Maybe they need a couple injections. And God forbid my chiropractors hear me saying this from years ago might want to kill me. But there is a time and a place where they might need a little help from another discipline so that they can help us do what we have to do better, right? Yep. And so now after they come in, now we can do a little bit more. We get a nice correction made, and they might be doing physical therapy in one of our offices at the same time with heat, stim, massage to, again, make our correction job easier. Now we do a correction, and now either we tell them how to exercise or the therapists now get them exercising to reinforce the new position we just corrected them in.
Yeah.
Whereas I have patients come to me sometimes and they say, Doc, I think I just want to do physical therapy and not get adjusted. What do you think? And my answer to them is, that's your decision as a patient if that's what you want to do. But if what you want to do is strengthen the muscles to hold your bones in the wrong position,
Exactly.
go ahead and do it. And you might feel a little better when you walk out, but if those bones are still in the wrong position and we haven't made a correction, it's going to come back, those symptoms, at one point, right?
I can't tell you how many times I've seen patients that they come into the office, they said they had therapy, and they never exercised in their lives. And all of a sudden they're going to therapy, and they're bent over to begin with, and all of a sudden they're going on a stationary bike,
right,
or something like that.
Right.
You know.
Yeah, but it's not that it's not that the therapy is not good for them.
Exactly.
At that point in time, it might not be good for them.
Exactly.
That particular therapeutic modality.
And it helps. And it helps us.
Right.
Do what we have to do.
Exactly. Well, this has been a very enlightening show. Thank you for coming. Can you please just speak to the audience, tell them if they have any questions, how they can contact you, your phone number, email address?
Okay. My phone number, you can call the office, 631-447-2299, 631-447-2299. Or you can email me at dgold66916 @AOL.
And your office is in Medford. You also have an office in Smithtown.
Yeah, we have our main office is in Medford on Route 112, and we also have an office in Smithtown on Jericho Turnpike.
Right. And besides us being real good friends, we're always consulting and banging things off on one another, ideas and things about how to treat patients better all the time, right?
Yep.
Right. Yeah. Well, I want to thank you once again. Thanks again, Dr. Goldman. So that wraps it up for today. Thank you for watching. For those of you who are watching us on Madhouse TV, stay tuned. We'll be right back. For those of you watching us on Cablevision Channel 20, we'll see you next time. And remember one thing, if what you want is real wealth, join us next time on The Bridge to Health. If you're watching us on Madhouse TV, stand by. We'll be right back. If you're watching us on Cablevision, we'll see you next time.
Thanks for watching.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi, I'm Wesley Walker of the New York Jets, former All-Pro wide receiver. You're watching Bridge to Health at Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi, welcome back to the Bridge to Health. My name is Dr. Tom Dow, and each week on our show we have a special guest from a different healthcare discipline who works as part of our integrated team to help you, the patient. This week I have the great honor of having a renowned gastroenterologist with us who we've worked with for many, many, many years, Dr. Mehta. Hi, Dr. Mehta.
Oh, nice to meet you.
Thank you very much for being on our show today.
Thank you for inviting me.
So we're going to explore a lot of different topics today, and we're going to try to explain to the audience exactly what it is a gastroenterologist does, how important it is for them to see a gastroenterologist at certain times in their lives. And so first of all, why don't you just tell me a little bit about what exactly is a gastroenterologist?
Gastroenterologist is a specialist who treats the disease of the GI tract, which involves anywhere from your mouth, you're going to the esophagus, stomach, small intestine, and the colon, as well as diseases of the pancreas and some degree disease of the liver.
Excellent. And so you went to regular medical school, and then you did your residency and specialized in gastroenterology, right?
That's correct.
How long is that residency to be a gastroenterologist?
Well, after medical school, we do 3 years of training residency in internal medicine. After the 3 years in internal medicine, we subspecialize in gastroenterology. When I trained, it was a 2-year fellowship program, but now with the expansion in the amount of knowledge, amount of new diseases we've come out with, it's become a 3-year fellowship program. So it's 6 years after your medical school to become a gastroenterologist.
What are some common conditions that you treat on a daily basis or see or diagnose?
Some of the commonest GI or gastrointestinal problems we see and treat on regular basis are number one, gastroesophageal reflux disease, or what people call GERD, described as heartburn. That's one of the commonest gastrointestinal diseases we see. The next common we see is what we call irritable bowel syndrome, called as IBS, known as spastic colon, various names it goes by. The third thing we see is people coming in for their routine colonoscopies, because as you know, colon cancer, second commonest cancer both in males and females, and as general public, everybody is becoming more aware of this disease. More people are coming in to get their screening colonoscopies, and of course if they found something, then they follow up.
Right.
Other common disease we see is what we call inflammatory bowel disease, which under that there are subgroups of what they call Crohn's disease, ulcerative colitis, and there are other types of colitis we also see.
Okay, so let's go back to the first one.
Sure.
Let's talk about acid reflux. That is when a lot of people, they call it agita. Oh my God, I just ate something spicy. I got this burning here. I can't make it go away. And most of the time they take a Tums or they take a Mylanta, an antacid. What exactly is happening in people's GI tracts when they feel that?
Very good, yes. Actually, gastroesophageal reflux disease by far is one of the commonest GI, and probably even in general regular practice, one of the more common symptoms patients complain of. On an average, it's been said that 40% of the general public have had episode of at least one episode of what we call reflux disease or angina, heartburn once a week. Some people, and then a fair population more than that, but at least 40% get it once a week. What actually happens, why do people feel this burning, is the gastric contents, of which the most important is your hydrochloric acid, the acid that stomach makes. It comes up above your EG junction, or the junction between the esophagus and the stomach. When it travels up into the esophagus, it causes severe burning.
Why does it come up?
Okay, there are several factors that then cause. Normally, let's look at why doesn't it normally come up. We all make acid in the stomach. It's important in our digestive process.
Right.
Why doesn't normally? Because we have certain what they call protective mechanism, of which the most important one is the LES, which we in medical term we call LES. It's the sphincter or a valve between your esophagus and the stomach.
Is that the pyloric sphincter?
No,
It's
this
different,
is
okay.
different.
Okay.
This is called esophageal sphincter,
Okay.
which is at the lower end of the esophagus.
That's like a little hole that opens and closes. It's
Closes,
like a
right.
valve, right? And that
Exactly.
and normally that would keep the acid in the stomach.
Exactly. The valve actually remains most of the times closed, and we now have ability to measure the pressures in people who complain of a lot of heartburn. When that pressure is not maintained in between you, it only actually opens up when you eat to let the food go through. Otherwise, normally it remains closed. When for various reasons that valve doesn't work to its capacity is when acid reflux occurs.
What would be some of those reasons that would stay open like that?
Okay, there are some food products that when we consume on regular basis have been known to decrease that.
Wow.
Of that, the common ones actually chocolate and mint has been known to decrease the pressure in that.
Wow.
Certain carbonated drinks, because the carbonation when it enters the stomach increases the stomach pressure, which actually makes that valve not work normally, unable to close completely, and that makes the valve not completely closed and acid reflux occurs.
So it's not that the person's making too much acid, overproduction of hydrochloric acid, it's just that that valve is not staying closed, right?
Absolutely correct. Yes, it's more of the dysfunction of the valve.
And when they take an antacid like Mylanta or Tums or you know, that type of thing, it's just decreasing the acidity of the acid so they don't feel the burn as much, right?
Exactly. The symptom that occurs most of the time is because of the acid, because as you know, hydrochloric acid is a very strong acid, and your esophagus doesn't have any lining protection against that kind of acid. Right. So it gives you the burn. So when you take an antacid which is alkaline in nature, it right away neutralizes the acid, gives you immediate relief of your symptoms.
Okay, now the most common drug used to treat that condition is what, Nexium?
It's, yes, Prilosec, Nexium, Prevacid, which under all general fall under a term called proton pump inhibitors.
And what do? They don't decrease the acidity. Do they affect the valve?
No, they do not affect the valve. They actually decrease the acidity.
Oh, okay. So it decreases the hydrochloric acid production?
Exactly. Exactly.
How do people still digest food if they don't have the hydrochloric acid?
Very good question. And I actually, a lot of, some of my well-educated patients do ask me that question. They said, oh, I think hydrochloric acid is important in your digestion, and it absolutely is. You see, acid is produced by pumps in our stomach called proton pumps. When you take this medication like Prilosec, Nexium, Prevacid, it does decrease the production of the acid anywhere from 40 to 50, maximum on higher doses up to 60%. So you're still producing some acid. So you're not cutting down the acid to zero. Your digestive process doesn't completely shut down. To some degree, does it affect some digestive process? It probably does, but not to a significant level that will affect your nutritional absorption or your nutritional condition.
Okay, excellent. Now, a lot of people come to me as a chiropractor, and they say, I have hiatal hernia. What is that?
Okay, very good. Hiatal hernia is also one of the conditions that leads to acid reflux. Hiatal hernia is what happens where a part of the stomach, the upper part of the stomach, migrates up into the chest above your diaphragm. Normally, in a normal anatomy, your esophagus is above the diaphragm. Right at the diaphragm is where you have the junction of the esophagus and the stomach, and that's actually the diaphragm which actually also helps to keep the valve closed. And then you have your stomach. Now, due to certain conditions, which we can elaborate further, your part of the stomach migrates up. Once it migrates up, now you think of part of your stomach is sitting up in your chest. And now you lost that valve because, like I said, your diaphragm is mainly acting also help you with the valve. So you lose that valve. Number two, as you know that your chest every time you breathe causes a negative pressure. So now when your stomach is in the chest, it's causing a negative pressure, acid is already sitting there, you're going to have more acid reflux.
So basically the hernia is in the diaphragm muscle which goes across your body, and instead of it being this big, it might be opened up more and the stomach comes up through it.
Absolutely correct. Absolutely correct.
Interesting. And how do they treat that? Is there surgery for that, or do they leave it alone? What's the treatment?
Yes, there is surgery, but not everybody with hiatal hernia needs a surgery. There are various levels or types or degrees of hiatal hernia. One of the commonest we see is a mild or very slight sliding hernia, in the sense that the hernia is not present all the time, but under conditions of increased abdominal pressure with a full stomach, when they're doing strenuous activity on a full stomach, at that time your stomach slides up.
Can it get stuck up there and not come back?
In very rare condition, it does.
Is that a dangerous condition?
It can become a dangerous condition, again under certain conditions. Thank God for 90% of the time it slides back down when that activity, your pressure in the abdomen is decreased when you stop doing whatever is increasing that pressure.
Wow, very, very interesting. I've heard, not heard, but I've had read a lot of articles actually, which people have heartburn, they have burning in their chest that they think is from something they ate, but it could be indicative of a heart problem too, right?
Absolutely, absolutely.
Have you had patients come into your practice with those symptoms and you work them up and you find out, hey, it's not a stomach problem, go to a cardiologist?
Absolutely. In fact, many a time when patients come to me with this heartburn, but when I take a detailed history and I see they have fair number of cardiac risk factors, before I subject them to any procedures, I tell them to see a cardiologist, because I hate to see any cardiac event occur during an endoscopy or a procedure which I'm doing, because as you know, heart is definitely much more important organ.
Absolutely.
So absolutely, yes.
Absolutely.
And so that's something that, I mean, younger people less of effect. If somebody with 20 years old comes to me with more of this heartburn, right, I would of course think, but if it's somebody older with risk factors, yes.
So I think it'd be, valid to say and important to say to the audience who's listening to us that if you're having chronic heartburn and for a long period of time, just don't dismiss it and say it's heartburn. It might be something more serious, and they should really find out what it really is, right?
Absolutely. I have had quite a few patients who actually ended up getting stents, and all their heartburn was cured after a cardiac stent. Absolutely.
Wow, very, very interesting. What is, I've heard a term called Barrett's esophagus. What is that?
Yes, Barrett's esophagus is actually a medical term we use when the lining of the lower part of the esophagus changes from its normal, which is a columnar type, to a from a squamous type, to a columnar type, which means it is becoming a precancerous condition. It has been attributed, it occurs secondary to chronic long-term exposure to acid from the stomach. Now there is also new thinking that it's not just the acid, maybe it's the acid and the enzymes and the other gastric contents, maybe a little bit of bile, but definitely acid plays a major role in this transformation of the lining to a precancerous type of lining.
And what do you do once you find that?
Once we find that, number one, the most important thing is we need to aggressively control the acid in the stomach. Like, you know, acid does play a major role, so we put them on this medication we talked about, like Nexium, Prilosec, or Omeprazole, which are proton pump inhibitor. And first, so number one is to control their acid. Number two, since it is a precancerous condition, we do surveillance endoscopies on them and do these biopsies to make sure those changes, because if it's a precancerous doesn't mean everybody will get a cancer, but now we want to survey for those who are going to get cancer. So there are these certain changes that occur in the lining which you can see microscopically. So we do this every 2 to 3 years, do an endoscopy, do biopsies. If there's any changes occurring, then either we treat aggressively or send them for surgical. There are other treatments available, right, radiofrequency ablation to treat that.
Does the esophagus have any digestive function, or is it just a tube that passes the food down into the stomach?
It's purely a tube that passes the food, has no digestive function.
So the lining of the esophagus has no absorption ability. It's not like the lining of the rest of your GI tract, right?
None at all. Yes.
Somebody should come out with an invention where they have some type of coating they can coat the esophagus with, you know, spray it in there so in case they have a problem, it's not going to get burnt, right?
That'd be the idea.
Make $1 million.
That's right.
Interesting. Okay, so you have a patient come to you, and they are a 50-year-old male. They've never had a colonoscopy before. Is it time for them to have one? Is that the right time? Should they have had it before? What's your views on that?
Okay. It's absolutely. Now, when a 50-year-old gentleman comes to the office, or male, female, doesn't matter, once you're 50-year-old, it's definitely indicated by American Cancer Society, Gastrointestinal Society, that you should get what is called a routine screening colonoscopy. Why? Because colon cancer is the second commonest cancer in both sexes, in male and female, and
second most.
Second most
wow.
common. And in both the cases, in all cases of colon cancer, we know all cancer start as a polyp. And a polyp which we can remove at a colonoscopy, during a colonoscopy, has prevented the cancer coming on. So absolutely, when a gentleman or a lady walks into or a patient comes into my office with age of 50, even for another reason, I always mention to them, if you haven't had your screening colonoscopy, it's time to do that. Now you also asked me whether it can be done before age of 50, and there are certain indications where we do them before the age of 50.
Like if they have a family history of colon cancer?
Absolutely, a family history. Again, a family history where one of their first degree relative has had colon cancer before their age of 60, because we do it 10 years before the youngest member in their family had colon cancer.
Right.
So if they had somebody who had colon cancer in 50, they should actually start getting screened at 40.
Gotcha.
So it's because the reason for that is, we know from a polyp to cancer is about 7 to 10 years, and the idea is to pick it up at a polyp stage. We don't want to wait to find out I have a cancer, then I didn't do any service to you to go and tell you now you have cancer, get it done. What we like to do is prevent that cancer coming on.
Right.
So in order for me to prevent, I had to pick it up at a polyp stage, take out the polyp, thereby I have prevented the cancer coming on.
How long is the colon, and what part of the colon do you actually look at when you do a colonoscopy?
Okay. Colon is anywhere from 3 to 5 feet on an average person. When we do a colonoscopy, we go from the rectum, which is the lowest most part, all the way to the cecum, which is the proximal end of the colon just before the small intestine joins. Also in some cases, and in as many as possible, we also try to look at the distal part of the small intestine, because there are some diseases that are peculiar or limited to that, such as Crohn's ileitis is limited. There is a certain condition called carcinoid, which is a benign tumor, which is often seen in terminal ileum. So, and over the years in my practice, when I have done that, I have picked up a few cases which were totally asymptomatic, meaning they were small size that didn't become, but if they didn't want picked up later in the life, it would have grown and caused them a problem. So we picked up those cases and had those surgeries and saved them some future problems.
On a previous show, we had a radiologist here, and he was telling us about the abdominal CAT scans and 3D CAT scans of the GI tract, and he was telling us that basically it's extremely diagnostic for polyps and cancers and things like that, and it could actually pick them up when they're not in the lumen but actually in the wall sometimes, which a typical colonoscopy, you can't look in the wall, it's just what's in the lumen, right?
Yes.
So do you utilize that technology prior to a colonoscopy, or in addition, or in conjunction with it, or what?
No, now yes, what he probably was telling is, yes, CAT scan we do use. Now let me tell what are the conditions we use CAT scan. One is whenever I diagnose somebody with a mass in the colon suspicious for a cancer, definitely one of the steps we do after that is to get a CAT scan, and this is to rule out where the tumor has spread into the wall, beyond the walls of the colon.
Right.
But the 3D, what he may be talking about is what we now call virtual colonoscopy. That's the name being given.
That's what it was, yeah.
Now, virtual colonoscopy is a 3D where you do CAT scan at a shorter intervals rather than 10 mm 5. It's a high resolution, and then the computer creates a 3D image of the colon. It has been good in picking up polyps in some cases, except that depending on the type of machine and the person reading it, there have been problems with, they have not been able to really identify what they're seeing. Is it a piece of stool or is it a true polyp?
Okay.
Now,
so it's not a replacement for a colonoscopy?
No, it's not a replacement. And number two, is that one is purely a diagnostic, meaning if you see something where they're not sure, they're going to send you to a gastroenterologist to get your colonoscopy now.
Right, right.
Now this technique and availability has been out for quite a few years now, at least 5 years plus. The reason it hasn't been picked up and many insurance have not is a couple of reasons. Number one, the most common is you still have to take, most people when they come to colonoscopy, one thing that the reason people are not coming that as often as they should or as when they should is the preparation. Most people fear, oh, I have to take that prep, I'll be running to the bathroom,
right.
I can't go 2 days or a day without eating.
Right.
The thing is, when you go for this virtual colonoscopy, unfortunately you still have to prep.
Same
prep. Because if there is stool in the colon, like I told you, the CAT scan can't differentiate, is that a piece of stool or is there a polyp hiding behind the stool? I don't know.
Right.
The little advantage I have during colonoscopy, even if somebody has not done the prep completely, when I'm looking directly, I can see a stool and I can see a colon, and I can wash when I'm there.
Right.
Through the scope, I can put this jet of water, clean up the stool and look underneath that, which you don't have that ability during a virtual colonoscopy.
Interesting.
And then the patient, when you tell after a virtue you took your prep, but now we see something now, go to it, so you'll have to take the prep a second time before you go. If I'm doing it once, I want to get it done right, do the thing that I can not only get a diagnostic, but if there's something, it's taken care of at the same time. So many people then have preferred. And because of this, and because of some of the overread and depending, many insurance are not covering that virtual colonoscopy.
What about this little camera I've heard that you can swallow and it travels all through your GI tract and it can look at everything from the mouth all the way out? What is that about?
Yes, that is called capsule endoscopy, and we do provide that service. It is basically a camera which you swallow. It is continuously takes picture every 2 seconds of your GI tract as it rotates around. It transmits, you wear a portable device on your belt which actually transmits all those images into that device. What you do is, the day before we put you on a liquid diet, you come in the morning, you swallow the pill, and that day you remain on a liquid diet. You go around doing what, about 8 hours later you come back, we take off the device, we hook up in a computer, and we look at through whole series of those images.
Wow.
Now we do that under certain conditions. One of the common is when we suspect somebody has Crohn's disease that hasn't been picked up. Crohn's disease is a condition where you get multiple ulcers which can be anywhere in your GI tract, from your mouth, stomach.
So is that an autoimmune disease?
It is, we don't really classify, but yes, it can be classified, but it's not a true autoimmune disease.
They treat that with like the biologic drugs, right?
Absolutely. Humira, Remicade, Humira, absolutely, yes. So it's a condition. So that is one of the conditions. Number 2 is some people who have had anemia where there's presence of blood in the stool. You've done an endoscopy, you haven't found anything. You've done colonoscopy, you haven't found anything. Then the only way to look at is their small intestine.
Right.
Now before this capsule was available, they used to do what we call GI series, where you had to drink this ton of barium and sit and yes, sit in your radiologist's office for hours where they took X-ray after X-ray. Here you get this capsule, you go about, we get the picture, and we have found in fair amount what they are called the small ulcerations, because they've been taking aspirin, and aspirin not only causes ulcers in the stomach, we have found it to cause ulcers in the small intestine. We see them to have this.
You still use that in your practice?
The capsule endoscopy, yes.
That's so interesting. It reminds me when I was a kid, they had this movie called Fantastic Voyage. Remember that movie where they took the submarine, they shrunk it down, they put in a needle and injected it in the person's bloodstream, they were able to see everything that's going on?
Right.
That's pretty cool. That's really cool. So explain to the audience, because I have many patients come to me that say, oh man, I've been delaying getting that colonoscopy done because it probably hurts. Does it hurt?
Not at all, not at all. See, colonoscopy, I know it has got a bad rap due to various reasons, and years ago, before we had this good anesthetic agent, what we call propofol now, I used to do them even before propofol was widely available and used, with what is called Versed and Demerol, which are some. But the problem with that is we were doing the procedure where we used to give the sedation and do the procedure, so we used to little under sedate. You don't want to over sedate.
Right.
And then the reason you get pain during colonoscopy is, in order for us to look inside, we have to insufflate air. You think of your colon as a tube which
air.
have to, air to
blow
inflate.
the person up, yeah.
So it's like you're getting severe gas cramps, and that's very painful.
Right.
So, and some of the medication, of course, the problem is if you over sedate, then their breathing becomes a problem, so you don't want to do.
Well, you did mine about a year ago, and it was totally painless. It was, I'm glad I got it done, and thank God everything was okay, but I waited too long like most people do. So I would encourage everyone, if you haven't had a colonoscopy yet, and you're 45, 50 years old, that even if you have no symptoms, you should really go get checked out preventatively. You can prevent yourself a lot of problems. And Dr. Mehta is an integral part of our healthcare team. We use him for consultations in all of our offices, our office in Melville, our office in Ronkonkoma, and Hicksville, because we have patients come in as primary care portals of entry doctors with a multitude of symptoms. They may have back pain, which might be referred from their abdominal tract. So we have to be able to rule out every possibility when you, the patient, comes to our office, and we need to have the team assembled to be able to accurately diagnose what's going on with you and get you the best possible help that's out there. Dr. Mehta, can you tell the audience how they can get in touch with you, or maybe a number they can call if they have further questions, a website?
Sure. My office is located in Riverhead, right off Route 58. The address is 36 Osprey Avenue in Riverhead. They can certainly call my office. The number is area code 631-727-4171. They can go to Eastern Long Island GI Doctor.com. That's the website, and certainly we'll be more than happy. We'll be more than happy to help you with any questions you have as far as your GI tract is concerned.
Thank you very much, Dr. Med, and thank you for being my guest today.
Thank you. My
and
pleasure.
We're definitely going to have you back on the next show.
Thank you.
Thanks very much. And for those of you watching us on Madhouse TV, stay tuned. We'll be right back. For those of you watching us on Cablevision, we'll see you next time. And remember one thing, if what you want is real wealth, join us next time on The Bridge to Health.